Good evening. It's a great privilege to be asked to come in and speak this evening. I'm aware I've got the twilight shift, so my primary objective is to keep everybody awake for the next half an hour. But I hope a secondary objective is that you'll find what I'm going to say challenging and interesting, and it will be applicable to you all. This is about all of us, because we all live in the 21st century and we're all hearing about lifestyle issues. And diabetes is tied up in that, but it's not all what I'm going to talk about this evening. Now, you'll understand from my accent that I'm not from round here, and I grew up predominantly near St Andrews, and I promise you the only slide alluding to golf would be my final slide. I was, however, born in Oxford, so I feel that I've somewhat come home. It's not too far from here, is it? Now, I'll let you into a little secret before I start. Mary doesn't know this. I didn't say it in my interview, but I didn't actually really want to be a doctor. So when I went to my guidance teacher at school and said I'm not sure what I wanted to do, he basically said, "Steve, you're going to do medicine or law." That was it. Actually, what I wanted to do was social anthropology. I was really interested in how the human species had evolved over these millions of years and how we end up the way we are now, but I ended up doing medicine. But my first degree was sports physiology, and that really challenged my understanding of how amazing our bodies are and the physiology of our bodies. And I want to try and give you a few glimpses into that in relation to disease process. That's quite difficult because I'm a consultant endocrinologist, and most of you here are lay people. So I really hope to be able to transmit that message in a way that you'll understand. So please forgive me if I lose you every now and again. Listening to David's finance report, it's actually quite a common theme, a very fine balance between income and expenditure. But health and disease is a very fine balance as well, which I hope to demonstrate to you. And I will be asking some questions, so that's an extra incentive to stay awake. I'll be specifically looking at people and singling them out, so no chance for snoozing. Now, what's wrong with this picture? That's the first question. Apart from the cow,
they're too heavy.
They're too heavy, absolutely. This is not a plant in the audience. Eve, in particular, I would say, is a bit podgy. And in evolutionary terms, this wasn't how the human being was meant to be from a physiological point of view. That's not how we evolved. We evolved more like this gentleman here, who's an Aboriginal native in Tasmania, who is extremely fit and healthy, spends a lot of the day exercising, foraging for food, eats a very healthy diet, hunter-gatherer diet of fruit and nuts predominantly found in the bush. What's the prevalence of type 2 diabetes in this particular tribal group? Anybody hazard a guess?
0.
Can't all be plants. Okay. Now, what happens a number of decades ago was that many of the people living in these tribes with globalisation migrated into the cities in Australia, such as Sydney and Melbourne. And they ended up usually living very poverty-stricken lifestyles, eating a Western diet, being very inactive, drinking a lot of alcohol was a problem in the cities particularly, and ending up a bit like this man, busking with his didgeridoo on the streets of Melbourne. Shout out now what the prevalence of type 2 diabetes is with him and his comrades. 50? 30?
We've got a 30 over here.
You guys are good. I'm up against it here. Now, the even more interesting thing was that a researcher about 20 years ago, when I was a research fellow, persuaded a group as an experiment of people in Sydney to move back to the bush, to their villages, and to adopt the lifestyle they had. All of these people had diabetes. 90% of them, after 2 years, no longer had diabetes. This is a reversible illness if you catch it early. It's predominantly driven by lifestyle. And it gives us a glimpse into what the issues are in terms of central obesity and inactivity. And I'm going to try and take you through the mechanisms of that, if you'll bear with me. So what's the problem in the UK? What percentage of the UK population have type 2 diabetes then? Sorry?
You've had a 60, a 20 and a 70, I think.
6%. 5%, yeah. Hopefully not 60%. I'd be struggling with the clinic. It's probably about 7% if you include the people that don't know they've got diabetes. If you look at the obese population, over double the prevalence in those who are obese with BMI of greater than 30. But bear in mind that now 70% of UK adults are either overweight or obese, so there's a bit of a time bomb in the future. And if you look at the group of obese people who are BMI 35 and above, which is a rising group in the UK, then we're talking about fold difference of maybe 20 or 30 in terms of risk of diabetes. I'm talking about type 2 diabetes all the way through this evening. I'm not talking about type 1 diabetes. And if you look at an obese group versus a lean group, there's a roughly, on average, 5-fold increase in the risk of type 2 diabetes. This is, or I should say was, my recently deceased hamster called Daisy. And Daisy got me thinking. This is a picture of Daisy at 3 months. And this is a picture of Daisy at 2 years. And the thing that struck me staring at Daisy every day was that despite putting in far too much food, more than she needed, she always stayed the same weight. She never deviated from the weight that she started off as a fully grown hamster. And basically hamsters do two things. They run around in their wheel and they eat. They don't do much else. But for some reason they're programmed to exercise just enough every day to burn off the food that they've eaten so that they stay in equilibrium and don't gain weight and don't lose weight. And that is how human beings evolved as well. It's not how we live in the 21st century, but it is actually how our physiology over millions of years has been designed to take us through to a healthy end. Now Daisy actually did inspire me with her hamster wheel, and I did try and set up the same thing in the house. It didn't work that well actually. It's quite uncomfortable to go around the wheel when you're not a hamster, believe me. In the humans, the crucial area for deciding whether you're full, so you're eating a meal and you think, actually I've had enough now, it's a satiety message, is the hypothalamus. It's right in the center of the brain there, and it's absolutely crucial. It also helps us to regulate our exercise, our activity habits, and our temperature, our basal metabolic rate, so it's crucial for keeping that fine balance between calorie intake and calorie burn. The problem is in the 21st century, we have much more factors that influence our behavior than our animal urges, if you like. As I said, over a lifetime, we have a very, very subtle balance between what we take in terms of calories, what we burn in terms of our basal rate, or the organs that use the calories, and also, on top of that, how much we exercise. And I'm going to come back to this at the end and ask you some more questions, because there's quite a challenging message there for health and disease. It's a fine balance, indeed. The problem is that technology came along. One of the worst enemies in our society is the fridge, I believe. It's packed full of goodies. We walk past it a lot of the time and we're tempted to open it and eat something from it. This isn't my fridge. Thank you. And we really should put health warnings on fridges, because the way that food is made and packaged and processed these days makes it very attractive, very tasty for us, and it overcomes our hypothalamus, and we tend to eat more than we need to eat. And some people actually make an enemy of their fridge, like this person. And other technology has come as well. I'll come back to dogs in the end, actually, but this is an American way of walking a dog, which completely defeats the purpose, and it's quite dangerous, actually, especially for a dog. But the really terrible bit of technology in the 21st century is our young people. And the combination of comfortable sofas and screens and bags of crisps make for an increasing prevalence of childhood obesity, which will translate in 20-30 years' time into an increasing prevalence of type 2 diabetes. And we can see this, I'm sure you can see this walking down the high street in Basingstoke. You don't need to be a scientist to understand it. So if you'll bear with me, I'm going to tell you a story. And this story is about two American guys called Ralph and Ethan. And this is them when they were 12 years old and mucking about in a car having a sly smoke. But they were pretty fit and healthy in those days, in the 60s and the 50s. Running about, still pretty lean and fit, healthy lifestyle, post-war. This is them, age 22, college grad photos. And again, both playing basketball, lean and fit, healthy, weighing 70 kilos, 11 stone. Typical American guys, really. And what you want to do is imagine them 50 years has passed, and they're now both 72 years old. Ralph, on the left here, has stayed fit and healthy. He's kept himself in good shape. He's put on a bit of weight, but a lot of that has been muscle. He's now 80 kilos, 12 stone 6. He hasn't seen his GP ever. His past medical history is 0. Now, Ethan didn't fare quite so well. Ethan's put on weight, and crucially, he's put on weight around the middle, and that is a very bad sign for metabolic and cardiovascular disease and diabetes, for reasons which are quite complex, but I can mention. He's 110 kilos, he's 30 kilograms heavier than his mate, Ralph, 17 stone 3. And his past medical history reads something like this. Type 2 diabetes, arthritis, sleep apnea syndrome, he's had knee replacement, went on to have a heart attack, suffered from depression and still does, experienced a foot ulcer due to peripheral neuropathy in 2008, went on to suffer a stroke which left him impaired with mobility. He was registered blind with diabetic retinopathy, went on to have treatment for bowel cancer, was diagnosed with liver cirrhosis even though he'd never touched alcohol in his life. He had the early stages of kidney failure in 2013, is now heading for dialysis, and last year was diagnosed with early dementia. For any of you working or have previously worked in the health sector, this list is depressingly familiar. Many, many people who come through the front door of the hospital have exactly the same list of diagnoses. And all of them, as I'll go on to show, can be traced in part to lifestyle. Being obese has mechanical issues such as putting weight through hips, knees, ankles, chronic low back pain. Sleep apnea is partly a mechanical issue in terms of the breathing. And all of these significantly impact on the obese person. The joint problems and the back problems is a double whammy because those are the very people who you're advising that need to increase their activity, increase their calorie burn, and they're the people that struggle to do the exercise. So you get into a bit of a vicious circle when you're obese and you have joint problems. What are these? Fat cells, that's right. They're quite beautiful actually in a strange way, aren't they? We imagine that they're just there to store fat, but actually they seep out very toxic products, lipid products, which go on to cause disease. And I'll mention this in the subsequent slides, it's something called lipotoxicity or lipid toxicity. And actually we think of diabetes as a disease related to blood glucose or blood sugars, but actually the predominant complications of diabetes are related to lipotoxicity, toxicity from the fat stores. Now the first thing, I mentioned central obesity. The reason why that's so important is that the fat stores from central abdominal obesity drain into the liver. That's the first thing that they hit. And this is a fatty liver. You can see that the fat, well, you can't see it's enlarged because you've nothing to compare it with, but believe me, it's enlarged. And all the whiteness within the liver there is fat deposit. This is somebody with central obesity and type 2 diabetes, metabolic syndrome. Now, that can lead to diabetes, but it can also lead to inflammation in the liver and cirrhosis, and is increasingly becoming a problem for the gastro-union, the people coming in with cirrhosis problems who don't necessarily drink very much alcohol, and it's all related to fatty liver disease. Since I got this slide, I've never touched foie gras. The liver processes the fat that's draining from the central stores and turns it into even more toxic lipids, which then go around poisoning blood vessels, which I'll mention in a minute. In addition, the liver makes glucose. So that's why people with diabetes who don't eat for 24 hours still have high blood glucose, because their liver is making it, because it becomes very resistant to the effects of insulin. So you get a double whammy of lipotoxicity and glucotoxicity. Pair that with inactivity. This is fatty muscle. And if we don't exercise our muscle, it turns into fatty muscle. If we take a carbohydrate meal or a snack, 70% of that is taken up by muscle. If the muscle is not active, if the muscle hasn't been exercising, it doesn't take it up. And the blood glucose ends up going high instead. This is a condition called insulin resistance. And when you combine the liver making too much glucose with the muscle not taking it up, then you can see why the blood glucose rises in diabetes. That's compensated for by these things. Quite pretty. Anybody know what these are? These are pancreas cells, the islets of Langerhans. And amongst those are beta cells that make insulin. And in the early stages of diabetes, people are making actually too much insulin because they're trying to overcome the liver and muscle problems that I've described. But eventually, they give up and they can't keep producing insulin, and full-blown diabetes sets in. And that's when you get glucose toxicity, because the levels of glucose in the blood go up and affect other organs in the body. So this is about a 3-hour lecture put into one slide. In my simple brain, this is what happens. You've got a combination of fat toxicity, lipotoxicity, glucotoxicity. That causes all sorts of problems, but essentially, in a nutshell, it causes increased aging of all the cells in your body. And it does that by cell damage, it does that by DNA damage, mainly by a process called oxidative stress, which is a natural aging process. It's why we all die eventually. And it's been calculated that type 2 diabetes, central obesity, metabolic syndrome probably accelerates aging by about 10 to 15 years. 10 years is taken off the average person's life because of that metabolic condition. So it's pretty serious stuff. And you get organ damage, like liver organ damage, kidney organ damage, DNA damage, blood vessel damage, both small and large blood vessels, and nerve damage. And so all the complications of diabetes can be explained by this fairly simple mechanism on different organs in the body. So for example, the glucose toxicity affects the small blood vessels behind the eyes. You can see the hemorrhages behind the eyes that can lead to blindness. And you can also see the effect it can have on the peripheral nerves, causing numbness in the feet and often going on to foot ulceration, which a lot of patients in our beds have foot ulcers. That's one of the big problems we have as inpatients in the hospital. This is a blood vessel. Dr. Bishop deals with these clogged up blood vessels every day in the cath lab and coronary unit. These blood vessels can go to the heart and cause heart attacks if they're blocked. They might lead to the brain and cause strokes if they're blocked. They might lead to amputations because they're blocked going to the leg. It's the same process. It's the lipotoxicity causing these plaques in the blood vessels. And it's the glucotoxicity causing the stress on the tissues and causing the coagulation of the blood. And if you have type 2 diabetes and obesity, you are a time bomb for a premature cardiovascular disease. Any idea what these cells are? This is cancer. And there's an increasing body of evidence to suggest that people who are obese and have type 2 diabetes are possibly at double the risk of some cancers. And it's probably through the same mechanisms as I've already said, the premature damage to cells, particularly to DNA, which can cause mutations and go on to develop cancer. What's this a picture of? Neurons, yes, so the green neurons. And can you see all the red plaques here? This is the kind of plaque disease you get in Alzheimer's or dementia. And again, there's an increasing body of evidence to suggest that the same toxic milieu which you get in obesity type 2 diabetes can cause premature dementia. And as we know, this is a huge time bomb for our current population. And finally, difficult to find an organ picture, but depression is a very important factor in this whole picture. The reason being that it's quite difficult to disentangle depression from obesity type 2 diabetes because they interact with each other in many complex ways. And often the psychological factors that lead to somebody becoming overweight and inactive is because of primary depression, and so the physical thing happens. But it can happen the other way around. If you end up with these diseases, then you become secondarily depressed due to the effect that those diseases have on you. So that's a very complex thing, and something which we shouldn't underestimate when we treat these patients. So just to remind you of Ethan and the big long list there, you'll spot that I've alluded to every single, and explained hopefully in simple terms, every single condition that he has can be explained in terms of those mechanisms. Remember his compatriot, Ralph, who's a bit short of 5 stone under. So over the 50 years between then and 1965, the only material difference in these guys, they had the same upbringing, they had the same gene pool. The main difference is that Ethan put on 30 kilograms predominantly around his middle in terms of fat, and Ralph didn't, and he stayed fit. I've told you that there's a very fine balance between calorie intake and calorie burn. I want you to tell me, I want you to quantify that for me. So I want to do that in 2 ways. I want you to assume that both of these men, over that whole 50 years up to now, have done exactly the same amount of exercise. They've been exactly the same activity levels and have burned exactly the same number of calories. So what we're dealing with here is a difference in the calorie intake over the 50 years. How much is that? And the currency I'm going to use is Skittles. How many Skittles, or how many bags of Skittles per day would Ethan have to have eaten more than Ralph to put him into the positive calorie balance that led to that massive health difference over the 50 years? Shout out.
Half pack a day.
Half a pack a day. We'll start with half a pack a day. 5 packs a day. 1 pack a day. 2 packets a day. Give me in terms of numbers of Skittles, because we've never counted how many numbers of Skittles are in a packet, unless maybe somebody has. 20 Skittles? 100 Skittles coming from the chief executive? Must be right. 50?
5.
5? Interesting. Why did you say that?
Because I think this sort of exercise is always good to go for an alcohol.
You're a very astute man. But you know what the answer is?
3. Well done, John.
Does anybody know how many calories a Skittle has? 4. 4 calories. 12 calories per day. It's a very fine balance. And sometimes the message we give to patients is, oh, you have to go and exercise in the gym 5 times a week for half an hour, and it's going to be awful, and you're going to be sweaty and feel miserable. 12 calories a day. Let's put it another way. Let's imagine that Ralph and Ethan had eaten exactly the same meals for the whole of the 50 years. The calorie intake was identical across the 50 years. How many more minutes would Ralph have had to have walked over and above what Ethan was walking?
10.
10 minutes? 5 minutes? 15 minutes? 20? 50? Keep going down.
Go on, John. 2.
That's quite challenging, isn't it? The subtle difference there is between Ralph and Ethan is of that magnitude in terms of lifestyle, and yet the difference in their outcome, in their health outcome, is absolutely massive. And we need to sell, I speak as a health community, we need to sell that message a lot more. I think we make it too difficult for people to adhere to a healthy lifestyle. If people understood the magnitudes over years and decades, then maybe there'd be more incentive to not eat the 3 Skittles or go out for an extra couple of minutes of walking every day. So just about done. But I knew that David was going to be here, so I thought about putting some finances up. I'm sure you know this, but the NHS in the UK is 10% of the whole of the gross domestic product, so it's a massive investment by the taxpayer. Of that, 10% of the whole NHS budget is related to diabetes. And that's rising because of the epidemic proportions I'm telling you about. Now, when you translate that into numbers, we're talking about £14 billion of diabetes costs per year. And in the last minute that I've been wittering on, another 25,000 has been spent. So this is big news. And interesting, this is something I didn't know until I got a refresher on this recently. 2/3 of those costs are related to inpatients. And we can see that in our hospitals. We go around and do diabetes ward rounds, and 15 to 20% of the inpatients at any one time in our wards have diabetes, much higher than the prevalence in the general population. And the length of stay is much longer as well. 20 years ago, when I was a lad, it was quite easy because people developed diabetes when they were 66. You put them on a couple of these simple drugs and then they died at 68 with a heart attack. And they didn't have it for very long. Now, what we're seeing is people with type 2 diabetes developing it in their 30s and their 40s. We're giving them lots of drugs. Dr. Bishop's opening up their coronary arteries. And they're living for 30, 40 years with diabetes, which is great. That's wonderful. But the drug complexity and the drug spend has increased massively. And this isn't even all the drugs that I could think of. This was off the back of an envelope yesterday. The complexity of the therapy in type 2 diabetes has increased massively. And that's relevant for a reason I'll tell you about in a minute. So in summary, we're talking about over 3 million people in the UK with diabetes. And that's going to go up in most of our lifetimes. I've told you that 10% of NHS spend is related to diabetes, and that's going up. The vast majority of cases could be prevented by a healthy lifestyle, but that very subtle difference, that fine balance of calorie intake and calorie burn. Unfortunately, once people become obese and develop type 2 diabetes, lifestyle interventions are very, very difficult. And it's partly, I told you about the mechanical issues involved, the body image, the confidence issues about exercising when you're heavy, the psychological issues, the relationship with depression and so on. So we have to use drugs. And the complexity of those drugs increases almost on a weekly basis. I am a diabetologist. That's what I do. And I struggle to keep up with the new drugs that are coming out for type 2 diabetes. In the background, this is political. Government strategy is to reduce diabetes specialists across the country and to devolve the care of these highly complex patients with all the complexity that I've demonstrated in Ethan to primary care physicians who are very good, but they're not trained specifically in diabetes and they do not have time to to keep up to date with the complexity of it. And there was only one image that I could think of when I was downloading images from Google. And it was that one. Last couple of slides, if you bear with me. In Glasgow, I used to run the pre-diabetes clinic, which was trying to identify people before they got diabetes and trying to intervene before. And I used to go on and on and on about diet and lifestyle and try and persuade them, try and bring them on board to reduce their risk from moving into diabetes diagnosis. I had very little success. I can't be very persuasive, obviously. But I had 2 patients over a couple of years at that clinic who I had success with. And both of them had gone out and bought a dog. And so my theory is that we should issue everybody with pre-diabetes with an NHS dog. And it's not just because you walk the dog. In Glasgow, you have to have a dog to go out for a walk, because if you didn't, you'd get mugged. Possibly murdered. So it's a necessity. So usually an Alsatian or a Rottweiler. I'm sure in Winchester, a wee Spaniel or a Poodle. But obviously, if you can walk the dog for another 2 or 3 minutes a day, then that might be enough to keep you in calorie balance, yeah? The other thing that's really, and this struck me with these 2 patients in particular, they came back to the clinic happier. And that, they had a reason to live. They had a companion. Maybe they were on their own. Maybe there was not much point in watching your lifestyle, because who cares anyway? And then having a dog, having a friend, having a companion made all the difference. So I think that's a huge factor. And the final one, of course, is the post-war granny syndrome. I can remember when I was a kid eating my minced potatoes. It was pretty awful at Granny's. And I got about 2/3 of the way through and thought, oh, I'm finished, I'm full. She was saying, finish your plate. And we're kind of, a whole generation's been engendered with this, you must eat everything on your plate, even if you're full, even if your hypothalamus is screaming at you to stop. But this is brilliant, because if you've got a dog, you scrape the leftovers of your plate. You're not wasting it, the dog's benefiting from it. You can hear your granny saying, oh, okay, at least you're not wasting it, that's all right, that's fine. And so you don't feel the guilt, and you don't take so many calories in. Now it's true, Liz, the dog may get diabetes. But you just have to walk it more so it doesn't. The proof, the scientific proof that having dogs is significant to your health is that this guy's pretty muscly. And the St Andrews golf slide is my final slide for which I'll leave you. Just to say that exercise is often perceived as being tough, sweaty, embarrassing, painful. Actually, exercise can be highly exhilarating.